Golden.
Great. So yeah, thank you everyone. So welcome to the very first National Community of Practice, and this one is focusing on the co-production standard of the best practice standards for Wales. And we're specifically looking as part of this community of practice for supporting and looking to work with community neurological services. And I phrase it like that deliberately because I'm aware that many neurological services are very broad in how they sort of provide services to their population. Some of them called Live Well services or similar. So we're trying to really encapsulate lots of different services that provide neurological support. As I've mentioned for those who've already on the call, there is, as part of the best practice standards, there are some self-audit tools as well, which we've put onto an MS form, and the QR codes are available there. And it'd be really good for us throughout all of the sessions that we have together to try and get a sense of where services, third sector, and people with lived experience, service users, feel that how we're delivering on these best practice standards. So this will be a common feature throughout all the sessions. So if you've got an opportunity now, just to click onto the link or scan the QR code and complete that form, it really doesn't take very long, and it would give us a lot of really good information. So we really appreciate that if you could do that for us. Thank you. So in terms of today, so yeah, looking at co-production, which is the first standard of the best practice standards. Well, I just want to let you know what we're going to be looking at in terms of that today. What does that look like? So there's a welcome and introduction. So my name's Nick. I'm the National HP lead for the Neurological Conditions Network. And it's been a real privilege to be in this role to try and set something like this up. And I'll explain a little bit of the background to that as we go on. But what I'd really like people to do, we're not going to have a chance to go through introductions in person or online really. So what I'm going to suggest people do is, if they want to, put something in the chat box just to introduce yourself, your role, your service. And then that might give us some opportunities for people to connect and to try and connect the dots and link up with others. So if that's something you'd like to do, then feel free to put that into the chat box. So we're going to be looking at the background of the community of practice very quickly. Ruth Crowd has very kindly given us an address, and Ruth is the Chief AHP lead for Welsh Government. We've got co-production Wales then with Gwendolyn Stirk presenting. We'll have some time for discussion. Then we've got Cardiff and Vale Live Well Services, Rachel Wallbank. She'll be presenting how they approach co-production within their services. Some more discussion. There's a little bit of evaluation then towards the end, and then there'll be any other business. And throughout this, if there's any questions at all, I'm really happy for people just to put a hand up. And Ellie, if you can see a hand for me and let me know if anyone's got a question, please just either pop in the chat or come forward and let me know. So the background of the community of practice. So there were several engagement events in October last year where people were service users and providers were talking about the need for enhanced community services and bolstering community services. And I'm sure many of you will be aware of the Cabinet Secretary's sort of release and the Ministerial Advisory Group release there about bolstering community services and trying to improve access to community services, primary care and community services. But there's also a call for sort of better networking and sharing of good practice that's happening in Wales and trying to link services up so we can all understand what good looks like, and then how do we go about delivering that and supporting each other to do that. So following that, I've done a lot of stakeholder engagement, so speaking to people. Many of you on the call I would have spoken to already, one-to-one or in groups. And we sort of landed on developing a community of best practice, feeling that this would give us the best format and the best platform to do so. So how are we going to do that was always the question, and giving it a real focus. So we decided to fix on some best practice standards and use that as a framework, and that seemed like a really good and sensible place to start. There's lots of different best practice standards out there, depending on where you're looking. But we're really lucky in Wales. We've got these all Wales community rehab best practice standards, and the 7 standards within that are really useful for what we're looking at here, because they're not specific to any one condition. They're broad enough to allow us to have services that can support a variety of people based on their need, not necessarily purely their diagnosis. So we can fit that into the neurological services umbrella really easily. And these are sort of core standards that we should all be looking to implement and work on in our services. So we've got 7 standards here, but some of you may be aware that we've got 9 sessions planned for the year, and that we're trying to finalise the dates for the rest of the sessions. The agenda's pretty full, but we've got to get the dates booked in. And the reason we've got 9 is that it gives us flexibility to have a couple of sessions related to evaluation of the community of practice, but then also for us to plan what we're going to do with the community of practice going forward into the next iteration of it. And in terms of the makeup of this community of practice, you can see on the call, we've got clinicians, we've got people in strategic roles, we've got researchers who come to join us later on in some of the sessions, we've got people with lived experience, and we've got third sector organisations. So we've got a really good blend of people working across this area to try and get the voice of each sector into this conversation to make sure that we're all delivering these services to the best possible standards that we can deliver. Now, trying to set the tone a little bit, so with some housekeeping, so I'll just go through this very quickly. So the culture and ethos of this, so the idea of this community of practice, as I've mentioned to many of you, is really trying to develop a supportive culture within our networks to try and support each other, to have a really good forum to discuss the challenges that we've faced, how we've overcome them, and then how we can link up and share that learning to support us to deliver best practice standards or take initiatives from one area and deliver it into another area, and whether it's scalable or spreadable. So really trying to maximize the opportunity of this networking opportunity, but a really supportive environment. I'm personally very happy with people having constructive critiques and constructive questions. But just bear in mind that we're not here to criticize anyone. We're here to, or put any one service on a pedestal. It's really about trying to share the learning across Wales to make sure that we're all working towards delivering on these best practice standards and trying to enhance services as much as we can going forward. I've put a link in here about recording sessions, and this is some advice that Public Health Wales, which is the exec's host body, they've got some guidance on what we need to do with recordings of the sessions and what we need to consider. So there's a bit in there for me as the chair currently about my conduct and how I need to work with yourselves to make sure that the session is fair and that behaviour is appropriate. But obviously there's a responsibility on everyone in the community of practice and online to do that as well. So the link is there, and we'll share the slides for anyone to have a look at that if you wish. Storage and dissemination. So initially we'll be storing these recordings within the exec, but we know that that's not accessible to everyone. So what we're going to do, and Ellie's looking to support on this, is to try and get these recordings onto a YouTube channel so that we can then share them for everyone who doesn't have access to the initial storage because they don't have an NHS Wales email. A little bit about etiquette. So if possible, I know people are probably eating, etc., but if possible, try to leave your cameras on, microphones off when others are talking. Try to be engaged in a session as much as possible. And I know all too well it's very tempting to check your emails in the background when someone's giving a presentation, but really to try and get the best out of this community and to take the learning, it's going to be really important for us to engage in the sessions. I know 2 hours is a long slot really for some of us, but trying to engage as best we can and to try and maximize the meaning and the learning from these sessions. Before I share the address from Ruth, has anyone got any questions or comments this far? Okay, 3, 2, 1. I think that's okay. I don't know if anyone's got anything. If there's questions in the chat box, someone just let me know. But what I'll do is I'll just change my screen. I'll go to Ruth. The reason I've asked Ruth to give an address for this, because I think I've had a few meetings with Ruth, and she's very good at setting the tone, and that the power of AHPs working in this space, but also the sort of what we can do as a collective and how we can take these ideas forward. So I'll just move my screen. I think I need to stop sharing and share a different screen. And if anyone has any problem with the sound, let me know.
Good afternoon. I'm really sorry I can't be with you in person, but I'm really thrilled to have the opportunity to talk to you this afternoon as you hopefully start this amazing new community of practice. I want to thank Nick for inviting me along to just have a few words with you today. I hope and expect that many of you will have seen the Science Evidence and Advice report that was published over a year ago now, and the way in which that identified the demand that will be growing for our health and social care services over the next 10 years. It clearly identifies the growth in our population's demand for healthcare, the multiple conditions that they are living with, and the fact that those conditions are not conditions that we will solve with single episodes of intervention, but we need to be providing them with lifelong, ongoing care, but not just making them passive recipients of that care, ensuring that they are able to take part in shared decision making, understand what is best for them, and to really lead the management of their own care. And I think that is particularly important for people who have neurological conditions. So, the way in which we are going to be able to tackle that demand is really by ensuring that we build long lasting, long supporting, community place based, person centred integrated services. And if any of you have heard the Cabinet Secretary or the First Minister talk about our priorities over the last few months, you will have heard how clearly we need to build our preventative early intervention and our long-term community-based support services. And that really has to mean including rehabilitation. We need to make sure that we are focusing on what matters and that we're being person-centred. And those are words that in the HP world we've used for many, many years, but we really do need to examine what we mean by that. How do we actually deliver interventions that focus on what is important to the person, that is actually going to make a difference to enabling them to live healthier, happier and longer lives? In 2018, we published the AHP framework, which identifies clearly what allied health professionals need to do in order to deliver a healthier Wales. And that is about ensuring that we move from our central secondary care focus into much more preventative, direct, early access services based near where people live and able to be reached through a shorter number of handoffs and steps as possible. We need to think about the fact that our population isn't living with just one condition, but are often living with several long-term conditions. We also need to build that other end of the pathway, if you like. We need to be building that rehabilitation, rehab, reablement, prehabilitation and recovery service that is about that enabling people to maximise their ability and to live well with their condition. When I came into post in 2018, there was very little mention of rehabilitation in policy. And I'm really pleased that as well as the AHP framework, we now have a public health AHP strategic framework for the UK. But in Wales, we have a rehabilitation framework and really, really clear rehabilitation standards for community services that will help us get this right. Nick has asked me to talk about some of the challenges of working in community services. And I recognise that moving from what we've always done to what we now need to do in order to meet population need is going to be an extremely challenging change. But if we want to have impact, if we want to make a difference to the lives of the people that we work with, then we have to do that. We have to start delivering for the 21st century, not 1947. Demand is hard to turn off, but the only way that we are going to cope with the demand facing us, as the Science Evidence and Advice document identified, is if we move to much more early intervention, much more preventative, and a much more educated population who can help themselves. So I think one of the big challenges is how you move from where it feels really busy to actually where you can make most impact, and how do you identify and agree where you make most impact. I think another challenge is how we build the respect of others who don't understand the skills that the allied health professional workforce brings, who maybe don't understand the power of rehabilitation or prehabilitation if you are working early to prevent people deteriorating. So how do we articulate that? How do we build something that looks coherent, that isn't different in every single service, so that we can point to what we do and say, see, that delivers this. I think we have to get much stronger at doing that. I think one of the challenges is ourselves. I've touched on this already. But are we truly willing to put the person at the centre in place of our expertise, our power, and our control? To do what matters, not what makes us feel good or what we're proud of or the skills that we've spent many years building up. That's not to say that we don't use those skills, but that we have to focus them in meeting people's needs. We talk a lot as AHPs about being holistic, about being person-centred, and about being different to the medical model and being very biopsychosocial. I think we have to start demonstrating that clearly. I think there is a real challenge in driving change. And the only way that we're going to do that is if we have an evidence base underneath what we're talking about and what we're being seen to deliver. How do we justify the inequity and variation in our current services? And so a real tool to help you overcome these challenges, I think, is about our learning from each other, our sharing of good practice across Wales, but across the UK and indeed the globe, so that we are making sure that we learn from others and we embed that into good practice. That will help us to articulate what we bring to the system, to maximising the health of our population, and why people should bother to employ us, because I think our skills are really critical. But unless we can articulate them, unless people can understand what we're doing, then we become very easy to overlook. So my message to you is that those challenges are hard, but they're achievable and they can be overcome. And I think one of the real tools for overcoming them is something like the community of practice that you are hopefully going to build from today. Having that leadership from Nick, leadership that you all contribute to as well, seeing each and every one of you, seeing yourselves as a leader, that's a really important tool for you actually to build the evidence, the understanding of impact, and to modernise and transform the services so that people with neurological conditions and other conditions really do get the best possible responses from us, and that we can help them to live healthier, happier and longer lives. So I hope you have a really successful afternoon. I really look forward to hearing the outcomes of the day and to working with you in the future. Again, I'm really sorry I can't be there in person, but thank you ever so much and enjoy the rest of your session.
There we are. Thank you. I probably should have said at the top of that Ruth really did want to join us today, but sadly there was a very close friend of hers had a bereavement, so she's supporting that friend today, and she was happy for me to share that information as well. There's several things that came out for me in that, and I know some of you might think, oh, it's it's a little bit strong towards AHPs and the involvement of AHPs in the delivery of services, but I think she talked really broadly around patient-centered, the need to let a person be at the center of our care and how we can use our skills as AHPs to bring that forward, but also that shared leadership and that everyone has a role in leadership. And I think for me that doesn't mean just clinicians amongst us, it means everyone's voice, and making sure that everyone is utilizing that voice in forums such as this to allow us to make sure that those voices are heard and that services are provided for what we need them to provide for based on person's need. Okay, so I don't want to take the airways any more than I need to. So unless there's any questions that have come up in the chat or anyone wants to ask a question, then I think we'll move on to our first speaker, which is Gwendolyn, who is CEO of Co-Production Wales. So if there's any questions at all? No, okay. Gwendolyn, have you got slides prepared? Are you happy to share?
I'm just going to try sharing them. It's always a bit of a worry whether it's actually going to work. Can you see that?
Yes, I can. Yes.
Brilliant. I'm also going to pull them up so that I can see my notes somewhere. So I know what I'm saying.
Okay.
Brilliant.
So I'm not doing very well at keeping to timings here, Gwendolyn, but I suspect about sort of 20 minutes or so, if that's okay, and then we'll try and have some questions and some discussion at the end. And really keen for service providers to think about how we embed co-production in our services, and try and ask some really good questions of ourselves, but also each other in the room as well. So yeah, over to you, Gwendolyn.
Oh, I clicked on and I didn't mean to. Sorry. Yeah, hello everyone. Thank you very much for inviting me. It's great to be here, and I've just been looking at who's in the room, which is fantastic to see. Lots of different people coming from lots of different perspectives. So yeah, I'm the CEO of the Co-Production Network for Wales. What we are is a network fairly similar to yourselves in a way. We're a community of practice, but we bring together a community who are interested in doing co-production across Wales. So they can be people with lived experience, people that are professionals delivering support both in the third sector, public sector, and actually we also have private sector and academics involved as well within the network. And our aim is basically to enhance and enable co-production to happen across Wales, so that we create a fairer and more sustainable Wales for everyone, where voices are heard and listened to within a whole array of services, from health services to environmental responses. So it's quite a broad subject area. But looking at your best practice standards and thinking about what you can do to embed co-production and how you can make it sustainable, I think, in these challenging times, are sort of setting out a bit of a sort of response to that, and hopefully providing some examples and resources that can really help you think about within your varying roles what that means. Because I think we're seeing what international researchers have sort of called a participatory zeitgeist at the moment, where terms co-production, involvement, and participation are being thrown around regularly. But I think we need to think about what that actually really means. And from a Welsh perspective, we've got some really clear and positive commitments, both through legislation like the Social Services and Wellbeing Act and the Wellbeing for Future Generations Act. And then that's really coming through now in these All Wales standards that you're looking at. But it's about making it a reality in the ground and making all of that kind of policy commitment and conversation. What does that really mean? What does the term co-production, it's a very jargonistic term in a lot of ways. What does that actually mean, and why is it prioritised? And from our perspective, looking at it at health in a health context, we believe co-production, when it's delivered, both improves individual health outcomes, but also population outcomes. It greases the wheels in the way services work with people, and it builds those trusted relationships between people and institution and organisations and services, so that we have an understanding of each other's experiences and how we can work together to solve things that we need to solve today. So yeah, I'll just give a bit of a brief framing of co-production, say some examples, outline sort of how we can perhaps support anybody that is on that journey, and hopefully leave some space for discussion to allow sort of questions, because unsurprisingly, from a co-production network, we're about conversations, we're about talking, rather than just talking to people. But I think it is worth me just to set like what co-production is, because I say there is a dearth of sort of, it's a term that's used a lot, and I think people don't always have a clear understanding of what it is. And it is very much from our perspective, you have to be bringing the intersecting of two groups of people together. Those that have professional expertise and experience, and those that have lived experience, expertise and experience. And it's the bringing together of those that makes this co-production. And it's when those two are working together through shared power and responsibility to achieve a mutual benefit of a caring relationship, that you get co-production. So it's that old disability mantra, nothing about me without me. That's the principle that underlies co-production. And it's a strength-based approach. It draws on people's lived experiences and communities' experiences. It combines those with the professional expertise, and it develops those solutions collaboratively and delivers those together. Sometimes you see co-production used and it might not be co-production. So if you're just in a room full of professionals, regardless of whether they come from the third sector and public sector, that's collaboration and partnership work. It's great. It's not co-production. If it's just community members and lived experience individuals in the room, that's community-based working. Again, a very important piece of the jigsaw puzzle, but it's not co-production. It's when we bring those two things together that we actually are seeing co-production happen. So, sorry. I think one of the questions we get, particularly at the moment with things being challenging and complex, is, am I doing co-production right? Am I getting the gold star for co-production or not? And from our perspective, we don't, it's not so much about ticking the box and getting it right, and also understanding that in some scenarios, co-production in its fullest form isn't always possible, but it's working within the values of co-production. And if you start taking consideration of these values, then you find you're on the journey to improving the work of working together, looking at how you can enable each other to deliver what you need to do and bring that together. So the 5 values of co-production are about valuing all participants, so professionals and those with lived experience, and understanding that they're all bringing strengths and you want to build on those strengths. Developing networks across silos, a very hard thing to do, I think, within the structures and systems that we're in, but it's about making sure that we create those connectivities across silos where we can. It's about doing what matters to the people involved, so making sure that we're focusing on what really matters, not making assumptions. Building trusted relationships and sharing power, so that it's not just about consulting somebody about what they do, but it's about actually sharing the power of decisions and trusting each other in doing so, and recognizing that it's people that will make the difference, that will change. Organizations create a structure and an environment for that, but actually people create that change. Foremost in delivering co-production, and when we talk to people in projects trying to do it, is remembering it takes time to do co-production well. It takes building trusted relationships between the different people within that space, which takes time to do that. And it takes honest and open conversations that will be challenging and difficult and conflicting at times. And you need trust and time to do that. So when you're thinking about co-production, I think make sure you're thinking about the time you've got to do it and start building trust. And that will start you on that journey of co-production. So within the framing, I think, again, I was looking at who's in the room and the different perspectives that people will be coming at from and different roles. I think when we start talking about co-production at that person-centered frontline service level, it can be quite a simple conversation in the sense of, if you are supporting or the person coming in and receiving a service at that frontline support, making sure that we're talking about how we work with each other to deliver that support and to enable that support, and build on the strengths of that individual, can be quite clear how the co-production is delivered. But it's then making sure that then starts feeding throughout the whole system. So that may be moving towards group co-production, and I think somebody in the chat mentioned that they were from a co-production group, which might not, it's not going to involve every service user and every person that might be impacted by the services or decisions that you're making, but it will give you a representative perspective and ensure that the communities and different perspectives are in the conversation in designing and developing a service. And then bringing that further up into the decision-making space, into the strategic level space. Are individuals' voices heard and influencing and being part of the decision at the top level? And I think this is it's a two-way process. And for people at a strategic level, there's a significant responsibility to create an environment where co-production can be embedded across the system. If you don't have it supported at the top, it is unlikely to be able to, even if, you know, at the front line, you're really wanting to work in a person-centered approach, you need that to be coming and being empowered from all levels of the organization to make sure it happens. So that's kind of, I say, I'm probably talking to some of you that are really embedded in this process and are doing it, whereas I suppose others may be at different points in their journey. So I don't want to go to too much detail, but I wanted to make this practical, make this useful, and give you some tools to go away with and think about, and also come back and you know, let us know if we can help you further on your journeys of co-production. So I've got a couple of things, and I'll share the slides afterwards so that you can, you know, there are links in them so you can actually access what I'm talking about and find out more. So I noticed that you had a self-audit tool, and I don't know whether this would be duplicating what you're doing, but we have a very simple self-assessment tool that's available on our website, but is also downloadable, which takes about 30 minutes to go through. And I know that some health groups have done them in Wales and use it regularly as a way of assessing where they're at with co-production, looking at what they've prioritised, where on the values they're doing well, where they might need to do further work. And it just gives you a snapshot picture and enables you to action plan your co-productive journey and where you want to go next. Some people do it as a team, some people do it individually to look at their within a strategy or plan. Others have used it within a co-production group to explore what they're doing well and where they want to go next. So that's an available tool for you to use. And then I just want to give you two very quick examples. And again, some of you may be involved in these examples. This one actually is one in process, but I thought it was quite a good one to share that we're currently working with Betsy Cadwallader University Health Board to look at a co-design process for their service user engagement strategy. And they've been working really to get closely together, both professionals and lived experience individuals, to drive forward that from instigation through to well, they're not at delivery stage, but through, you know, what they want that to look like, holding what the sessions of co-design would look like, so they're, you know, lived experience and professionals are informing the process as well as what will be delivered, and exploring participatory methods throughout that. And they are now at the sort of co-analysis stage of looking at what they found out in that process and what then they will develop into a strategy, and then look at how they will deliver that together. And that relationship through that process has really been built, and that will basically set them up with a foundation to deliver an engagement strategy as well as to have produced it. And then the next one comes from England, just across the bridge in Bristol, and this is more of a grassroots service, you know, a slightly different area from from the areas that perhaps you're looking at, but it's a sexual health and HIV service in Bristol, particularly targeting the African and Caribbean community. Where there was recognised a massive gap in accessing the services, the generic services that were there. And I think this service, which has been evaluated and looked at for its co-production, and I will share the slide so you can have a look at the research that behind that. But what they really did was spend the time to build those relationships and understanding from the community, allow for discussions of challenge. You know, there was quite a significant experience of trauma and pain within that community that needed to come to the front, and be looked at so that they could design a service that really came from the grassroots up. And now that service is really embedded in those communities in Bristol and delivering a support with them so that they can, you know, have got a really trusted and close relationship that has really worked at involving the community in the support. And it's addressed things like stigma that there was around accessing these services. It's addressed things like discriminatory barriers in accessing healthcare services. So they've taken a process of co-production and started from day dot, and recognizing they weren't going to know where it was going to go unless they started with the community. And then my next slide is just to say there is a lot of useful information out there. So what I've done here is give a list of ones I think that would be useful. So the audit tool, but also some of our information about how to make the case within your organisation, about what co-production is and why it needs to happen, because I know that sometimes that case needs to be made to strategic level. Our guide on how to set up a lived experience group if that is something that you're doing. Some case studies and stories to gain some learning about what is out there and how it happens. And then a link to our knowledge base where there is a wealth of information, if you want it, on how co-production works and what it might be within the settings that you're in. And just to say that also, we, as the Co-Production Network, are there to help. So we have the Co-Production Lab, where we have a pool of experts from a range of fields that can support both a service, an organisation, a partnership, or a policy area. We've done work with whole councils, or we've done work with a small co-production group within a small community setting to look at how you can go on that journey of co-production. It could be that we just come in and do some basic training, we do some coaching and mentoring to help people on that journey, or we hold a space so that you can have that conversation that you need to have about how you embed co-production in your work going forward. And so I suppose I always want to leave with a question. I say we aim to help anybody on their journey of co-production and look at working with you on that. So I suppose, what do you need for your co-production journey, and how can we help you on that? I'll try and stop sharing. Thanks, Nick.
Thank you, Gwendolyn. That's great. Really useful. I've got a few questions as well, but I wonder if we open it up to everyone in case you had any questions or any responses to Gwendolyn's question there at the end about what you need to support you in your services or health boards to sort of start your journey or continue on your journey with co-production. I wonder if anyone would like to come forward for that. Jackie, do you want to come forward?
Yeah, hi. Can you hear me? I'm having a few computer problems. Yeah, oh, lovely. Hi, yeah, thanks, Nick. Hi, Quentin. That was excellent. Thank you. Really, really informative presentation. So I'm Jackie Pottle, and I'm the National HP Lead for Palliative and End-of-Life Care. And in terms of co-production, we have a tool that's called, you may have heard of it, Future Care Planning Documents, which is very much about trying to work with patients and their families as to what matters to somebody as their health deteriorates. We face many challenges with getting people wanting to complete that, because it's often seen as a threat, and it's often almost seen as a death document. It isn't. It's supposed to be about future care planning. It's supposed to be much earlier than that, but obviously it does discuss things like funeral preparations and things like that. So people tend to associate it with, oh, you know, you're kind of saying that I'm dying. And you know, although a lot of people will be coming towards the end of their illness, sadly, and it's about making preparations, but it can be completed much earlier. And I would be really keen, perhaps, to do some work with you, you know, perhaps outside the meeting, to look at how we could do more co-production, because at the, you know, kind of, and work out how can we work with patients and families to really increase the uptake of it. You know, and the idea behind future care planning is that as a document is then brought into like hospitals, and it often isn't. So just to raise really that would be something that perhaps, you know, I'd like to connect with you and you know, have some discussions about. You know, I would find that really helpful. Thank you.
Yeah, well, absolutely. I'm more than happy to. My contact details, Nick can share them.
Lovely.
I'll share them. I'll give a copy of the presentation so that it can be shared as well. But yeah, it sounds like something that I think is a conversation. I think there's something there to like look at how document is co-produced, it has been co-produced, and also
Yeah.
how then there's a difference of how that's then used, and I think also with different communities as well, because obviously
Yeah.
end of life has a significant cultural context.
Yeah, I was at a talk yesterday to do a research talk with the European Association of Palliative Care, where they were sharing some findings of use of future care planning with patients with dementia in care homes. And there, in terms of co-production, they did a lot of work about actually working with the family members to really try and gain an understanding of both the family members' needs, but also the person that's living with dementia, their needs, particularly in a care home setting. And that sounded really exciting. And they were saying how much the increase in terms of working together with family members in the care home just massively improved the overall experience for everybody, you know, for the patient, for the family, and the people working in the care home. So I do think co-production has potential for so many ripples of improving care.
Yeah, it's, you know, we're similarly doing co-production on the very other end of the scale. We're talking about with one regional partnership about co-production with babies, and you think, well, what does a baby have to say about with its own care? But actually, you know, it's going to have a whole future life, and by working with the mother and the carer within that situation, similarly with as you were saying about the family members, you can actually do co-production that sort of looks at centering the needs of individuals from babies all the way up to the end of life.
Yeah. Thank you.
Oh, that's great. I've taken that as an action, so I'll make sure I share your details after the session. So yeah, great. Reese, you had a hand up. Do you want to come in?
Yeah, thanks. Yeah, that's a brilliant talk. It was really informative. I'm involved in 2 co-production groups currently. One with the Neurological Alliance, which is the England Neurological Alliance, but they have patients from a few different countries, from all the 4 nations of the UK that are involved in that group. And the one thing that I found with that is it's good because you know, you said about you have to have people of all levels, you know. Professionals, lived experience. The one thing I found was lacking with the stuff that the co-production group at Cardiff and Vale that are involved in Wales is that there's no decision maker input, such as like government ministers, whereas in the Neurological Alliance in England we were free to, we had set up a meeting with, you know, patients, parts of the people from the Neurological Alliance as well, and then you had the decision makers, and we met with the Department of Health and Social Care for a few hours, and I thought that was very meaningful that they listened. And then off the back of that, then in through England they've implemented a neurological it was, I think it was beginning of this year, it's like a neurological forum they've called it, where they're looking to address various issues in neurological care. And I was wondering if that's something that could ever happen in Wales, engagement with the Wales government, because the NHS is devolved in Wales.
Yeah, I totally, yeah, I agree that we need to have everybody in the room to do co-production, and it's great to see that that's happened in the England group. I think there is spaces where it is happening in Wales, and I don't think I've literally just come from the Wellbeing for Future Generations Commissioners just launched its 10-year its report, which is actually, and one of the things that's clear in that report, and it's obviously not just on health, but it's saying to the Welsh government that involvement, that, you know, under the Wellbeing Future Generations Act, involvement is one of the ways of working which all public services, including the NHS services, need to do. And it's saying that they haven't been good enough yet on that, and Welsh government needs to take some leadership on ensuring that involvement, which I take as being co-production and involving people with lived experience, needs to happen. That's a clear commitment that they're arguing to the Welsh government, and that's something that we're taking going to use that recommendation to push on it. But also, we're having conversations with strategic leaders across the board around how they do that, because I think, to be fair on strategic leaders in these spaces, I think sometimes when you've moved that far back from the front line, it can feel very distant and quite complicated to start to start going towards that process. So we're actually, some of the coaching and mentoring support we're doing is actually with strategic leaders to help them create that culture of co-production and engage.
Yeah. That's what I understand is, obviously when you've got co-production, you should have everyone from all capacities in the same area. Whereas if you're going through strategic leaders and they're going back to the government, you're sort of going through the channels as normal, rather than having all those people grouped together to discuss these matters, you know. And I think personally it's better to hear them from the people that it affects from the bottom, because they're the ones that are using services, etc. That's just my personal opinion on it, but I just wanted to put that forward. Thank you.
Yeah, I don't think you have many people disagree with you there, Reese. The power of a person's voice. You know, we're doing things to people, then we should really be listening to the people so we can do it together, rather than us sort of just
that's
doing
how
it.
we look at it. You know, we vote for politicians; they should be serving the people, and that's how we look at it on a larger scale.
Yeah, and we do have opportunities within the NHS exec, which is, you know, going through some changes at the moment. But in terms of the ability to act on behalf of policy leads, but then to bring people into the decision-making process, is within our gift, which is partly why forums like this are really useful for us, so we can start having these open conversations. Then with some of my other work within the NHS executive, we do have lived experience forums for specific groups of work. So this is a very early conversations that we've started in this forum, this community of practice. But I hope that as time progresses over the next year, people will realise that clinician voices and people with lived experience voices are equal, and that we can really influence services together, because it's within our gift to do that within these forums. Linda, you've got your hand up. Do you want to come in?
Hi there. I'm so sorry. Can you hear me okay? And I'm sorry, I was joining late, but I caught the end of that. It sounded, I'll certainly be watching it back if it's being recorded. I just wanted to comment on something similar to what Jackie was saying, that we're building co-production into our community neuroservices in an Iron Bevan. And it's been really interesting working with different communities. And again, it sounds a bit of a broad term, but there does seem to be differences. We did a little body of work with people who had brain tumours, and that was quite challenging. Sort of bringing people into the room at a time that was right for them, and having the time to build the relationships that were necessary to have a safe space to talk about some really difficult things around rehabilitation when it comes to something that might be progressive, like a brain tumour, compared to working with some stroke survivors, where perhaps they're younger and more active stroke survivors, and then there's the oldest. So there's not just this blanket neuro population. There's little nuances within that, and it takes sometimes a little bit of work. So it's not really a question, but just more of a comment, I guess, and maybe for some advice on how you go about working with those different groups.
Yeah, I think one of the things that sometimes we struggle with. So people say, "Is this co-production? What does co-production look like?" And we can't tell you that, because it depends on the group you're working with. Because every group you work with, the whole point of co-production is you make it look like that co-production because of the group that you work with. So that could be, somebody with, certain health conditions will have different needs to enable engagement within co-production, let alone sort of actually go through the process and the journey of co-production. And I think the other thing is to be comfortable to sit in the unknown and the grey, which is really, really hard. All of us struggle with that. But we have to start from a process of, we don't know where we're going to go, because collectively we're coming from lots of different perspectives, lots of different assumptions of where we think we might go. But we're going to be challenged on that journey, and we have to be open to that, to what's going to come from the lived experience, but also from the professional perspective, because you can't come in with a lived experience perspective, going, well, I want to have a swimming pool in my local area. And, that might not be possible. But it's sort of, So you might end up with, well, we're not doing that, but we're going to end up with having swimming lessons at, you know, a local, you know, the place around the corner. So it's always got to be a space of grey, space of unknown, and a willingness to hear each other, and exploring how. So I think it's creating a space where people can come and looking at what the needs of those people are to come to that space, and co-producing that. And also recognizing that we can't take our power hats off. We do, you know, I come in the room, I've got a title, I've got CEO, I can't take that off, it's there. But if you acknowledge it and say, but I understand you're coming in the room with a different experience and different power, and I recognize and see that power. I think that's the important place to start.
Thank you.
Right. I don't know if anyone else has got any other questions, but whilst we wait, there's a couple of thoughts I've had about how some of my personal experiences of finding the challenges or the daunting aspect of trying to undertake co-production, particularly with the fear of the time it might take and will I get the responses that I think we need, and trying to challenge perhaps some of my professional thoughts about, oh, I think this is what we need, and trying to be open to change in my own thoughts, and being really honest that perhaps I am the barrier sometimes to change in services. And I think that only comes through having a conversation and maybe asking yourself, and maybe I do this more now than my father, and my children, you know, constantly ask for things that I can't give them, and trying to reflect on, well, why can't I do that? Why can't I facilitate that? Right, not necessarily that my 4-year-old has good ideas all the time. You're going out into the garden to play with mud kitchens at 4 a.m. isn't a good idea, but the idea that if there's something I can facilitate and it's reasonable and it's within the gift, then why aren't I facilitating it? Is it just because I always do what I always do, rather than challenging perhaps my professional skills and think, can I stretch this a little bit different? Can I deliver what this person really needs? So I always think that's an interesting thing, and sort of links in with the challenges of a professional wanting to deliver on co-production, but also what's within the gift, and sometimes not knowing what is within the gift. As a clinician working, you may not always know what you can and can't do, because you might need to seek further approval, but maybe being more confident and comfortable in that grey area of unknowing, and trying to ask those questions and to maybe challenge where appropriate, because I'm sure we've all been met with resistance when we ask certain questions, but putting a good case for it. And so yeah, just some personal reflections there. I guess maybe not off the back of what I've said, but there's a couple of hands have gone up. So Emma, I don't know if you want to come in there and stop me from rambling.
What you said was beautiful, Nick. But I just also, actually, Gwendolyn, while you're in the room, I did want to ask a question, because one thing I found really hard, so the team I work in is also Linda's team, who also spoke. Can you tell we're a chatty bunch? But I've sat on a couple of spaces where we're creating clinical guidance, and I just really struggle sometimes with the kind of tokenistic kind of spaces that there are around co-production. And so, you know, so I work in a neuro rehab team, and this was for the speech therapy guidance around brain injury, and I'm trying to say, like, great, so how are we going to co-produce these? And they're like, oh, we're going to have a focus group, and there'll be at least 3 kind of people there. And I was like, yeah, but that's a focus group. That's not necessarily having these people in the room. And so I'm just wondering if you have any advice around kind of trying to champion, like, here is how we do this, like, you know, it's not that kind of tokenistic, like, yeah, we asked some people some questions and then that was it. Like, do you have any advice around how you guys have been successful in those kind of spaces?
That's why I think I always start from the values rather than this is co-production, because I think you sort of say, like, the people say, like, a focus group isn't co-production, because it doesn't necessarily share power. How are those people being the change maker within that space? You know, that's consultation, which has its space, and that's you know, sometimes that's what needs to be done, but that is not co-production. There is not shared power happening there, and I would say that there is probably a limited sort of enabling people to be, you know, those people that are in the focus group aren't going to be the change maker. And so that's where my challenge would start with these are the values of co-production, and I don't see the way that this is working as being fully part of that process of co-production. It may be an aspect and a way way forward. I'm very, off the top of my head, I'm not doing very well at thinking of examples. But definitely there are examples, and I think actually some of the case studies and links that I in the presentation will provide that. But yeah, what we usually start with is having a say, is it working within the values? Are those being addressed? And I think, or is this consultation? And we have actually with in some of our other sort of which wasn't in my presentation, but in some of our other materials and training, we talk about that ladder or a spectrum of engagement, and being clear, this is co-production, this is consultation, and when it's right to use it. And so perhaps looking at the ladder of co-production or the spectrum of co-production and saying, well, actually, this is co-production and this is consultation, and being clear on that.
Great, thank you.
Right, and then Tamsin, did you want to ask a question?
Yeah, and it was following on really from what you'd said, Nick, and a little bit from everyone else really. I work in neuropsychiatry services, so one of the things that we're often challenged by, and this is going to be similar across all neuro services, is how we demonstrate outcomes. And I wonder what insights and what learning you could share with us, Gwendolyn, about how we can utilize this kind of area to help demonstrate, to say this is what people are seeking in terms of outcomes, and this is how we demonstrate it. Because as a sort of a tertiary service that's funded by the JCC, we're getting drilled down on it, and we'd love to be to be able to do more, and we're looking into business cases, and I'm thinking there's got to be a way that we can help connect these two parts so that we can demonstrate value in terms of what people want and the way people want it, and at the same time be able to show that value.
Yeah, I think I've also been having conversations with funders as well to get them to understand co-production and actually understand that when they're funding a service, that they can't be, because they can't be just looking for outputs, and this, because if you're going to be doing it in a co-produced way, you don't know what those will necessarily be on the journey, because it's going to be they want it to be co-produced, they want it to be, often we're funders, I find, but they also want you to determine exactly what's going to happen at the end, like that, those two things don't match up. But I think for the case for doing co-production, there is a lot of research out there that sort of says that actually when you work in a person-centered approach, and a way that involves communities and individuals in the design and delivery of their service, either at an individual level or in a collective level to design the service, you see better outcomes and results for both the individual and the community. There is quite a significant lot of research, and I can definitely share some links to some research that's been done. Both, actually, I've got our Scottish organisation has been involved in on an international perspective, as well as our English counterpart, the Co-Production Collective, have been looking at measuring impact. And so there's some work there that is measuring the impact of co-production and its work. So both those could be useful, I think, tools in making your case to funders. But it also takes, I think, there needs to be a change of perspective within funders if they are going to start asking for organisations to deliver things in a co-produced way, which I think they should do. They need to also think about how they are measuring outcomes and looking at the ripple effect of a service, rather than just hard, outcomes that they've predetermined. I know it's going to be hard to get them on that journey.
Well, that's it. And
in the
even
meantime, there is plenty of cases that are showing it works. There is
Oh,
lots of research out there
and
to show
I
it
don't
works.
doubt that it's the how we can measure and what we can measure and
Yeah.
and what learning we can get from this network in saying, okay, that's a great idea. If those are approaches to use to measure that help us track this and give us different ways. Because we often, from a neuro rehab perspective, we often think about that qualitative approach rather than lovely numbers, but that's not always what funders are looking for.
Yeah, and it is going to be the qualitative. It has to be, because it's not going to be well, I think particularly because it'll be longer term impact as well. So numbers aren't necessarily going to come through until a longer perspective. I will try and look at that the measuring impact from co-production collective, because I think that might be a helpful tool.
Thank you very much.
That's great. Thank you. I'll take that as another action then, Gwendolyn. I'll relay all these actions towards the end of the meeting just so we're clear, and we'll circulate any actions as well. Okay, Ruth, did you want to come in there? This is probably, if probably final question before we move on, if that's okay.
It isn't a question.
Stimulated.
It's just a bit of a contribution to that last discussion about measuring outcomes. The Neurotherapy Centre that I work for, the MS Society, but I'm also linked to the Neurotherapy Centre, and they've developed with the people who use the service there something called a NeuroStar. That actually enables people to record what's important to them and then progress towards those points. So it's not necessarily in line with NHS requirements, but it is recording progress. And it does record progress around being able to kind of complete daily tasks, as well as other, really important things to that individual as well. So that's a tool that's been developed. And we did that because we were really aware that a lot of the tools we were using were actually really difficult for the people that were in the Neurotherapy Centre to complete.
Yeah, thank you.
Ruth, is that something you'd be willing to share to the wider group?
I don't see why not, but I just need to check back with the Neurotherapy Centre. But yeah, I'll get back to you about that, Nick.
Thank you. NeuroStar. Okay, I'll take that as another action then. Okay, great. If there are no more questions, but obviously stimulated a really good discussion there, Gwen. There might be a few follow-ups coming your way, which of course we're happy to facilitate. And if you want to get in touch or we can share emails, then please do use us. Okay, if that's all for now, then we'll move on to Rachel, who is on the call and hopefully got some slides that are working, and going to present Cardiff Vale Live Well Services and their approach to co-production.
Hiya, Nick. So I'm going to give this a go.
Okay.
But obviously, as usually is the case, IT normally fails me, and my IT guru, who is on the call but isn't sat next to me.
Okay.
So if I'm yelling for Hugh, he's going to have to run to come and help me. Or Ellie's actually got the slides as well. So I'm going to try and share. So let me just see if I can. Be helpful if I could share it. Let me just do it this way, see if this will work. No. Now, as always the case, I'm going to have, hang on a minute, it would be, you sat in the UHB health board and it never works, does it? You just try again. Ellie, you might actually have to share it for me, unfortunately. It's not coming up. Is that okay?
Yeah, that's no problem at all. Yeah, that's fine. Let me share my screen. If you just let me know then when you want to move on to the next.
Yeah, I'll do my best.
Okay.
I'll do my best.
Okay. There we go. Can you see that okay?
Yeah, can everybody I can see now my words. Perhaps everybody can see that as well.
We can see, we can see the sort of presenter mode there, Ellie, so we can see all the notes and the next slide. I don't know if
I present a view. Can you see that? Is that better?
So that's just the PowerPoint open. It's not as a slideshow.
Sorry, let me just stop sharing 2 seconds.
It's okay.
Hugh, where are you when I need you?
Yeah.
Or Annabelle can come and help me.
What room are you in?
Oh, I'm in the executive suite.
Yeah, Ellie, you're on the right screen. If you go back to what you had the second time and then just go into display slideshow, it should show the full screen.
So Hugh's going to come and help me now.
So click on slideshow at the top, on the top bar. And then from beginning.
Oh.
On the left, yeah.
And then, hang on, let me just
I think
sorry,
when
I do
you're
apologise.
selecting,
Splitting across two screens it is.
I got dual screens as well.
I'm going to go and help Rachel. I'll be now.
Yes. See, this is very co-productive.
Yeah.
This is at its best.
Very good. Yeah.
You know.
Okay.
There we go.
Back.
There
Yay.
Rach, I would have offered, but I'm not much better than you.
That's all right. Yeah, it's great. It's like the worst common denominator. So we'll start with this. So this is sort of Cardiff and Vale. It's the Live Well Services experience co-production. So hopefully this follows on from the fantastic presentation Gwendolyn showed. Hopefully it's not going to be a repeat of what we've learned so far, but perhaps just that grassroots experience. So I'm going to start really with acknowledgements because this is our experience of co-production. So although I'm delivering it, we know that actually behind this presentation is the co-productive voices of Rob and Natalie, who are our co-production Cardiff and Vale facilitators, the co-production group or forum, where Reese is actually a very active member. Thank you. Really widely, the team that I'm in. Oh, Hugh's now waving at me from the door. No, I'm fine now. Thanks. And so, yeah, the wider therapy team I also work for and with, and actually the health board, and together with Cardiff and Vale Recovery College and IMROC, who was the organisation that helped us in the very beginning within sort of the Live Well service about trying to implement co-production within our services and within the rehabilitation model. But also is saying, last but really not at means of least, is all the individuals that actually we've had worked towards and worked with over the number of years. And so kind of, I don't know if people know who I am, but I'm going to start this in a sort of introduction also in a very co-productive way. So co-production to us means that actually we're asked to bring our whole selves to meetings, to events, to service delivery, to those conversations with individuals. So if you don't already know who I am, so my name was Rachel, and actually I was born and raised in the borderlands of Northern England. So it's a land that's actually sandwiched between the Irish Sea and the fells of the Lake District. It was originally a land that was described as lawless. It didn't bow to Scottish or English law. And actually it was a land of, they called it there be dragons, but I'm going to come back to that saying in a little bit later. So there be dragons and grey have something in common. So that's kind of who we are. So next slide. So as a Live Well service, we're actually a collection of sort of teams and services that have come together to work really collaboratively together to work with a wide range of individuals living with multiple and numerous long-term health conditions. So sitting well in the middle of here is that's more pertinent to this meeting is the kind of Live Well core team, which was previously the long COVID rehab service, and also Live Well Neuro, who Annabelle is one of the service leads, and obviously Hugh is our strategic lead. And that was previously kind of known as a community neuro rehab team and the neuro physio outpatients. But we're very, as two services, work very collaboratively and share the resource of the skills and knowledge that we have in terms of our staff members and that experience. So next slide, please. Sorry. So in co-production terms, co-production within Cardiff and Vale, especially neurology services and co-production, probably Nick remembers this as well, started way before COVID, where we had the opportunity to look at how we would develop our community neuro services. And we held an event and had a wide range of stakeholders come to that. And so we listened to some of their voices, and actually it was a really tough event for some of us who were clinicians who knew best. There were the repeated comments of that there was a lack of authentic connections, that there was a feeling by individuals living with long-term neurological conditions that things were being done to them and not in sort of with their full collaboration or sort of awareness. There was definitely inequality and barriers to access certain of the services, that a lot of the services remain and were criteria driven. There's an absence of cohesiveness in rehabilitation recovery, that individuals felt often neglected, isolated from care or input, that felt also as well that there was a lack of holistic approach and working to focus on that individual's, not only their long-term health condition, but also their general well-being, and what actually living with that condition meant for them and their family and their support networks and their community. And that's often as well as where that we perhaps didn't as professionals be as aware as we should have been about the lack of sort of availability of what was out there for these individuals within the community, and that we weren't instigating significant trust and awareness of engagement with the communities and these individuals that we work towards. So that meeting was quite hard, but it was pivotal in Cardiff and Vale, and especially in therapies sort of vision actually how we should and we need to move forward. But obviously COVID happened, so a little bit of backstep. So next slide, please. So we've touched on this already, is about actually why do we need to do co-production? Because there's lots and lots of drivers. So ultimately, you know, a healthier Wales, Cardiff and Vale's health strategy, duty of quality, the community rehabilitation best standards, etc., etc. It's very evident that healthcare requires us to do this, and so it should. So next slide, please. This is just reintegration on the slides, which just as talked about previously. What is that standard? And that standard being that you actually, you know, rehabilitation is co-produced and supports people holistically with what matters to them, and what matters to them, what matters is their community and the people that support them. And next slide. I know I'm rushing this a bit, but never mind. And again, just really, why not? So I come here as a clinician, first and foremost, you know, I like to think, you know, rehabilitation runs core through me. And actually, I'm hoping that we deliver co-production really at that sort of cold face, that actually, if we're not doing co-production, we're not involving individuals in the care that we work towards and work with them, that we're not actually doing our jobs. So we know that co-production does form part of evidence-based practice. So there's often a drive in evidence-based practice that it's about the research, the best scientific evidence, but we know part of that is also clinical experience. What we've seen, what we know through years of practice, that anecdotal evidence that comes in front of the doors, what people say to us, but also patient values and needs is a significant part of evidence-based practice. We know it's part of that holistic psychosocial model. We know that it actually supports good key delivery of care that has meaning, that is quality, and that actually is prudent. And also in Cardiff and Vale, we're instigating and working really towards developing and instigating our rehabilitation model that actually works with the skills and strengths of the individuals and communities to ensure that we deliver rehabilitation at the right time, the right place, the right intensity for the individual, and actually with the right rehabilitation sort of individuals. So it's not just that it may be a qualified member of staff, but actually we use the key skills and strengths of all our staff within sort of therapies and other services. So next slide. So I know that Gwendolyn touched about co-production and what does co-production mean, and is there a right way to do it if we got a good gold standard? And she mentioned the guides and the audit tool, and they're really great places to start, and we do those over and over again, just to say, you know, where we are. And I think it's about this on the left hand side is really what kind of co-production looks like, or actually work with the individuals looks like. So we know kind of, oh, I'm missing bits. So if you press the button, it might come up. So at individual level, service level, and whole system level, which Gwendolyn touched about, is that we know that co-production exists at the individual level. So the individual is in front of you in that clinic space or in that group activity, that we have co-production also at service level in designing and developing services that have matter and value to those individuals, and whole system approach so that it's at strategic level. And as Risa pointed out, yeah, there is some frustration that often perhaps some of those decision makers aren't in the room, but actually perhaps then we can collaborate about how we sort of make that voice be heard, and actually the visions of the individuals that we work from within that sort of individual and service level be heard sort of wider and at more depth. So next slide, please. So I put this in also as well, where I've talked previously about there be dragons and that grey. So I'm not saying co-production is easy. It certainly isn't. When I spoke to him, so there be dragons, the individuals that work with me know I like antidotes and I always look for metaphors. So there be dragons is a term that's actually used by some business coaches and organizational business coaches, where actually there be dragons was written on maps where the lay of the land, they didn't know what the people looked like, they didn't know what the lay of the land looked like. Actually, the fear of the unknown was the greatest fear. And so actually acknowledging there may be dragons is an approach. Acknowledging the grey is a way for a mechanism to be okay in the grey. It is hard. I'm not saying it's easy. We often struggle with it, but actually just to say, actually, we know there are dragons, we're trying to slay them, we're trying to diminish them. So when I spoke to some people and myself when looking at that co-production, there was a really interesting thought that somebody said to me, feels a bit like when we in co-production, the worry is that we'll be airing our dirty laundry, that we're going to start having conversations where, do we know what we're talking about? I'm the professional, I know what I need to do. You know, I'm just really worried about it. And then also we know that it does take effort, which Gwendolyn has talked about, and it does take time. And actually also as well, I have heard, but what they know is wrong. So this fear about individuals in meetings, in co-production events, saying something that actually they feel isn't right or is wrong or being challenged, but it's actually changing that narrative, that vision to say, you know, that's the perception. We all are allowed a viewpoint and thought process to work through what our vision, our perception is. Some staff members were also concerned about that perhaps some of the comments they heard or were in meetings, that some of the sort of things that were said were about them personally. And that, I don't think that's ever been the case. It's about, you know, the struggles that people have had accessing services, and just accessing what they needed at the right time in the right place. So I think it's just overcoming that sort of concern and worry. So next slide, please. So Cardiff Mail, what have we done so far in terms of our whole system approach and therapies has been about setting up the co-production forum, where we appointed co-production facilitators, and we found that actually the outcome of that was actually we did create a really cohesive sort of community that actually did listen, has learnt together. It's a really safe environment. We've built trusted relationships. It has put ideas into action, which has been really beneficial. It's connected and strengthened the communities in Cardiff and Vale. We have a collective understanding, and it's about really about rebalancing the power. That's great. And next. So we have routinely in those meetings, about 50 people regularly contributing, 300 people plus on a mailing list, so learning more about kind of what that sort of forum and group is doing. We've had 30 plus co-production forums held, so we've held a mixture of online and face-to-face, and we've had several sort of specific interest groups established, develops very specific sort of developments that actually we've been looking at. So next slide. These are the people that have kind of come and been involved, so a range of organisations as well as individuals. Next slide. And I said the whole system impact, we've talked, this is what we've come out. So we've looked at the Live Well service has come from that co-production. Waiting Well has also come from that co-production. Aging Well, embedding co-production with other services, other therapy services. We've been really fortunate in actually what we've also managed to get over the line within our team is actually peer or lived experience practitioners. So they're active members of the team, ensuring at every level within our with our work with the individuals is that lived experience is front and centre in what we do. So that has been really significant. We've also worked on kind of stepping stones. So this has been an initial approach about how we looked at that kind of, I hate the word, sort of care planning documents. Somebody mentioned earlier on about a sort of co-produced document that supported individuals with palliative care. This is hopefully a document that aims at supporting individuals who have complexity of long-term health conditions and what we need to know about them and how they support themselves and their kind of expectations from us and sort of healthcare services as well. So we need to do a little bit more work around that, and that's one of our things that we're hoping to do. So kind of next slide. Going back to adopting co-production principles and values in the team. So we have gone back to our sort of therapists and kind of gauged, has your thoughts and feelings about co-production changed? So not so much the individuals in the co-production group, but actually some of the therapists who've been part of the journey. And actually most all felt that actually their confidence has increased. They had a real better understanding of co-production and actually the importance of having lived experience and expertise in supporting the development of services, communication and interaction. And actually a vast majority of therapists really feel sort of very passionate and empowered to ensure that actually co-production is front and centre within their services they aim to deliver. So next slide. And again, at service level. So this is our service level, as I said. Live Well service has come out of that sort of co-production design. So we've become a service that is much more symptom focused rather than a diagnostic focused neurological service. We offer group approaches and we look at using co-production, look at the design of the groups and the flexibility of the content of those groups. We have very front and centre shared decision making. That's a key implement within our services. And sort of in that co-production about the care right from the beginning, about, you know, sharing that decision about what matters to you, how can we support you, or how we can't support you as well. And that's often a difficult conversation, but we do have that conversation. We know that actually at service level, co-production is what has facilitated interdisciplinary working, and it is reducing the silo working approach. And actually, it also works in reducing the silo thinking approach. So I had a conversation sort of like last week with a colleague in mental health service who was really quite keen. He said, yeah, we can reduce silo working. That's okay. But actually what the barrier we need to break is silo thinking. So as professionals, silo thinking. And this is a way that I think we having sort of Cardiff and Vale and within the Live Well service, actually breaking down those barriers is what has sort of facilitated interdisciplinary working. We're looking at measurement and benefit, and that is supported by co-production. So kind of using narrative and the value of the narrative and the value for the individuals. As I said, we've got peer practitioners, lived experience peer practitioners. That also co-production ensures that we've got inclusive language and that is actually a value to those that actually are accessing the service. Slide. an individual level. So yeah, as I said, shared decision making. We do shared decision making both at a group and a one-to-one level. We've also ensured that actually it's supported education of staff with very psychological approaches to supporting individuals. So we've done a lot of work around motivational interviewing, bridges, etc. We use inclusive language, as I said, flexibility of group content, which is led by the participants, by the individuals and the community that's accessing our services. We have a choice of intervention programs, and that actually say that we can, you know, look at how we flex to meet the individual needs of those that are accessing us. Key also in sort of what we're trying to do as well is increase the health literacy of the individuals that are accessing our service, both through digital knowledge and the use of digital resources. And also what's come out of sort of co-production as well. We know about the goals aim that we're trying to aim towards. We've got some services within, well, some programs within our service that is re-referral. We're aiming for self-referral at some point, but we do have self-re-referral into the service. And several of us, probably me included at the beginning, took a big breath in and went, panic, but we're going to have sheer numbers of people coming. We haven't. So actually the power really rests with those individuals to make a decision when they feel they want to recontact the services and what that recontact may look like. Next slide. So kind of, as we said, it's an ongoing journey. There are lots of dragons. There will always be grey. We're trying to be happy with the grey and trying to sort of picture our dragons. And I'm not saying it's easy, but it is distinctly the best way forward. And we've tried to include with our staff members and wider that people actually who are therapists can bring their whole self into their therapeutic interventions, that they can be users of services and staff. Their lived experience also has value. We're trying to, as a wider service, as a wider therapy service in Cardiff Vale, interweave co-production as business and usual through therapy and our charter, co-production charter. We're trying to ensure that we've got permission to do things differently, and through that empower co-production champions. We're, as I said, always trying to say that we're learning through involvement and teaching each other. I learn vast amounts from my peer, sort of within my team, the peer experience, so practitioners. I had a really interesting conversation the other day with Chrissy, who actually the complexity of wheelchair services was sort of eye-opening, but I won't go into that. We know that co-production, we need to start at training level. So we need to make sure that our sort of new therapists coming forward at education level and universities know about co-production and actually the value, and actually use them in co-production as well. They will be our future workforce, so they have full value in designing healthcare systems and services that they're coming into. We know ongoing development throughout therapies and Cardiff Vale is that shared decision-making tool, that is the driver for change as well. That sort of individual level, that individual co-production level is a driver for change. And that hopefully we'll get more peer practitioners embedded in other services. So I think that might be my last slide. Thank you.
Thank you, Rachel. That's fantastic. That's a really good link from what Gwendolyn was saying to then moving into what the power of co-production can do, and in terms of helping you to essentially design a whole service to meet the needs of people based on their symptoms, breaking down those silos as well. There was a hand that popped up which has since gone down, I think, so maybe give me an opportunity to ask one question. One thing I'm interested in, Rachel, and this is something I've already reflected on in the session, is how have you supported professionals to sort of break down that professional, almost like an attack on their professional identity, I suppose some might see it, when you're breaking down silos and working more collaboratively or stretching your skills to work more integrated. I wonder if you could give us an insight as to how Cardiff have approached that to upskill staff, but then also to reassure them that, you know, it's okay to do things differently and to try and deliver on what you need to for services?
Yeah, I think that's a really good question, and perhaps, you know, I can go some way to answer it, but there are other people on this call that also are really active participants in sort of sharing the responsibility to do that. So I think we very much started with that. That has been the ask of lots of people, is that if I work interdisciplinary, if I don't work within my silo, I'm going to lose my core skill set. And that's never really been what I found. So I think, especially sort of Hugh, myself and Annabelle have tried to instill, is that actually about the confidence to take risk, the confidence, you can get it wrong. You have redefine what wrong looks like. And it is challenging. And sometimes also as well, it's, if I challenge somebody, it might not sit well, but actually we've been challenged by people in co-production. We've been challenged by our peer practitioners, and actually their questioning has had such much more weight, much more sort of validity, that's where it has worked. But perhaps Hugh wants to come in.
Yeah, I guess there is a bit of a challenge to our professional identity, particularly when we talked about this a lot. Like we ask people to spend a lot of time trying to specialize into what you get pushed into. You do your general rotations, then you go on to a more specialized rotation, then you're asked to specialize in a certain thing, and you become a highly specialized individual in that area. And then what we're then asking people to do is to take a step back from that and not have that inch wide, mile deep thinking, and think, actually, let's think about the person. So let's have a little bit of an inch deep and a mile wide thinking about what surrounds that individual. And that has been a real challenge, to be able to say to people, we're not diminishing the value that you have as a specialist in terms of the skills that you have to deal with those individuals in that way, but really to have a think about, when that person comes into the room, do they really require all of your skills, or can they be sort of looked after by some other teams in terms of that? And is it necessary that they have that highly specialized intervention? That's been a real challenge. One thing I would say is, when I was talking to one of our colleagues today around when something was coming up, I said, oh, and we'll put that through co-production in terms of like in when we're trying to design a new service, and I suppose the initial response to me was, oh, well, that's going to take ages. And I was like, yes, but at least we'll get something at the end of it that's going to be useful and that people want. And I think, and then I saw her reflect on that, and I said, and then we won't have to go back and redo it, because we'll have produced something that everybody's comfortable with and everybody's happy with. And I think that's what I would probably sort of say about all of this. And the work that Rachel and the team have done has been fantastic around supporting us to get the right offer out for those services that we're currently trying to support. So yeah, I'll stop talking now as well.
No, that's great. Thank you both. Linda, you've got your hand up. Do you want to come in there?
Yeah, sorry, I'm very interested in co-production, and that was a brilliant talk. Thank you so much, Rachel, and for your insights here as well. One thing that's kind of intrigued me is that this way of working feels very natural to me, and it's like I've been waiting for this my whole career, and then now I'm allowed to do it. And then when I talk to some colleagues, it doesn't sit very naturally. I realise it doesn't come naturally to everyone, or that so I guess Rob and Nat have been so generous with their time with me in helping us with our co-production journey, and I wondered about whether co-production is everybody's business, or whether you need to kind of invest in a core co-production team to get things started and to get that kind of credibility, because we haven't got that. We've kind of, it's just been because I really like it that we're fighting to get it going, and not just me, lots of people in my team, in fairness, it's something that resonates with us, but then I'm just wondering about growing it and making it more just a core part of business, a core part of every service, or what's your thoughts on the best way to go about that?
So I know where you're coming from. Yeah, so I'm with you that this sits really well with me. This is actually, I'm sure this is part of my core values of being an occupational therapist. But I think where in Cardiff and Vale, you're right, is I think we had a commitment right from the beginning from our sort of head or lead of services, Emma Cook, that actually in order to orchestrate co-production, to actually give it some traction, we needed to invest in it. So that investment was specific clinical or therapy time from it's one role, but it's shared between two people. They've got shared hours. That actually we had that investment in that, and actually for that value to be seen is that they're therapists, they are doing therapy work. This is a significant value as that face-to-face one-to-one. It's changing therapy, it's changing interventions. It is of high value.
I wonder if I so just jump on that, because I'm just thinking, Linda, I wonder if there's probably a really good opportunity now with the release of the Cabinet Secretary's sort of Federation speech, which essentially says that there needs to be a real big push into community and primary care services and to try and develop the capacity there, and whether there's an opportunity to go to service leads, health boards, and say, well, if we're going to do this and deliver on this well, and we've got some good examples of that, and we can share the links that Gwendolyn said about how to build your case, whether there's an opportunity to say, well, if we're going to do that well, to deliver on the long-term requirements of a health population, now's the time to do it with the additional focus. Now, that probably doesn't stop the need to provide some deliverables along the way, because that's something that we all have to contend with, I suppose, the long-term aim and the short-term responsiveness of healthcare. But whether there's something right now, this time, whether there's something we can try and utilise with the sort of the current attention on the healthcare. Hugh, do you want to come in?
Yeah, I'm just going to add probably one last bit into this, and I think reflecting back on how I used to work and how I work now, if I move back to probably even when I was in my community neuro role, I kind of felt like I was doing stuff in a very person-centered way. But I know now that having been through co-production and looking at stuff from a different perspective, how different person-centered looks now compared to what it did back then. And I think I think I would challenge everybody on this call to have a look at how they work and see whether or not they really are doing everything in their power to be as person-centered as possible. Because I think hand on heart, I can probably say I probably wasn't doing that back then. Whereas I think now, having looked at and the value that co-production's brought into our services, I think a lot of our teams now, we've really invested in this, and now we're reaping the rewards of a really person-centered approach to being able to deliver what maybe we were doing before.
Yeah, great, thank you. And I suppose just to support that, there's obviously the audit tool we've been promoting throughout this session, maybe a first chance for people to reflect on what they're able to, how they're providing on that co-production, because it does talk about patient-centered. And what we aim to do as part of the network is to share those responses back to yourselves to see how you feel they sit, but also we've also got an option for lived experience people and third sector to provide their feedback, and we can share that with you as well and see what the discrepancy is between lived experience thoughts on co-production, but also health boards as well, and try and reflect that back to you. So that's one of our plans with the audit tool. So if you have a chance to complete that, it's in the chat box, so please do that. Reece, you've been waiting patiently. Do you want to come in there?
I was just going to reflect on what Hugh just said. First of all, sorry, Hugh, about the captions when I first met you when they called you huge and they got it wrong, if you remember that. So I think from a patient perspective as well, I had a brain tumor when I was 8, and as I was growing up, I had problems with hydrocephalus and other things as well. I've had lots of brain surgery, 24 operations or 25, I think, altogether, so it's quite a lot. But having seen from when I started to understand it, when I ran about 2009, I felt then the care was a bit more sort of tell and do. You just, as a patient, you just speak to your consultant and listen. And I think it has evolved quite a lot since then. And you know, especially getting into co-production, you see it, you feel more involved in what happens. And like I'm completely deaf now, so I use the hearing services as well. And it gives you a chance to, you know, voice your opinion and give feedback. And I think it just doesn't benefit you personally, it benefits the health board, it benefits other patients as well. And you can be the voice, you know, because you notice things that necessarily, if you're working in that environment, you won't understand or won't see on a day-to-day basis because you don't live with certain things. So from from a lived experience, I think it's co-production is a brilliant thing. And it obviously, but I do think it takes that mutual agreement that you both need to respect each other in the capacity of both patient, physician, and beyond. You know.
Yes, great. Thanks, Rhys. Tanya.
Thank you, Rachel and Gwendolyn and everyone who's contributed. It's been really interesting and inspiring, encouraging afternoon. After a little bit of sort of just practical, I suppose, advice, thinking of, you know, within those co-production conversations, how were you able to include the sort of diverse patient population that we serve? So how, from a sort of thinking of the communication, the cognition, language, you know, sort of the, you know, poverty of getting people to places, transport, all of those things. What were some of the, sort of practical, psychological, philosophical approaches you use really to help that?
It's a really good question, Tanya. I think we haven't cracked it. It's still slightly our dragons. So we try to use a variety of means. So we've used some digital resources. We use expertise that is in those rooms. So not just ourselves, but the expertise that initially come along to access other communities. So it's like a bit like a spider sort of diagram, so reaching out into services. So people come and they go, well, I know this from this person from this organization, or I can have a conversation with them. And I haven't said, you know, we haven't got it right. We know that there are distinctly voices that we don't hear. And so we have to think about how we do things differently to hear those voices. And a bit of that is, you know, how do we know how to do things differently if we're not sure, because we haven't heard those voices to alter. So we go along to various sort of GP practices, cluster meetings, health fairs, just very willing to have open conversations and listen in the best way that we can, and be really open that, you know, actually, you know, we might have got this wrong, but can you help us, tell us how we communicate better? We obviously use skills that we have within the health service. You know, we've got great speech and language therapists who you kind of helped us with some appropriate communication, accessible communication, language and ways forward. And as I said, we're really keen, have always tried to be keen, that actually the therapists involved in co-production as well do come with lived experience as well, do come with long-term health conditions, do come with lived experience of supporting family members or being parts of community. So ask them as well to participate, not just with their professional skills and knowledge, but their whole skill set.
Thank you, Rachel.
That's it.
Thank you, everyone. I wonder if I just give, if anyone's got any other questions they want to raise, or any final sort of comments or thoughts before I start to draw the first session to a close. Okay, so I'm just going to share one last slide, if I can find it. I need you to run over here, Hugh, and give me a hand. I don't know if people can see that slide. It doesn't matter if it's on this sort of mode, but essentially we're just looking to draw those final thoughts together, and there's an evaluation here which I'm very aware that we haven't co-produced, but this is a form that we've put together within the exec. And one of the challenges I suppose we'll put back to you as a group is, if you've got any comments on how we can make this evaluation better, then let us know. We'll circulate that with a few other things. But I'll talk to that in a little bit. So final thoughts. So I think Ruth Crowder summed up the need for us to look at implementing best practice and the challenges that we're facing as AHPs and service users, and what we need to do to try and work together in this forum and outside of this forum to try and deliver on those best practice standards to make sure that people are receiving the care that they require and they deserve. We heard from Gwendolyn, which tells us what co-production looks like and how it could be delivered, and outline some of the resources and the tools that are available. So I'd urge people to have a look at those and link up with Gwendolyn and sort of gain knowledge and experience. If they need that extra support, then reach out for them as well. We've also then seen how co-production can be done and the ongoing journey that is. It's not a final product, it's an iterative process where things are changing and developing. And we've seen that in practice in some of the work that Rachel and Hugh have talked about today. And I think it's stimulated an awful lot of discussion, which is great to see. So one of the fears when you set these things up is they have a quiet audience, but it's good to see there's a lot of voices in Wales, and it just proves that everyone wants to do things to improve services for people. So I suppose I'll just run through the actions, but whilst I've got that, if people could scan that QR code or the link which we can put into the chat, if they could fill out that form, there's a different form depending on your viewpoint. So if you're a service provider, a service user, or a third sector organisation, and we're really trying to understand the value of co-production in this instance, but this form is to try and help us work out the community of practice. How can we demonstrate that people are going to benefit from having these sorts of conversations and interactions, to support us to tailor the sessions to make sure that you guys are getting the most out of it and these networks and connections. So I'm just going to read back some of the actions that I've collected, and to the rest of the guys in the exec on the call, if I've missed any, let me know. But I think the first one for me to mention is that we have written a draft terms of reference, and it's very draft, and what I'm proposing we do is we circulate that to everyone, and we'll take comment in the next session for anyone to try and change or tweak or work on what that needs to be, and we can keep reviewing that as we go until we're happy. And of course there'll be review periods, but we've got something draft, and I would really appreciate if we had contributions from every health board and every sort of perspective. So if I could ask people to look at that, that'd be really grateful. So there's the term of reference to go out, there's the links that Gwendolyn has shared, and the presentations that have been shown today. And we'll also circulate the audit that we've been asking you guys to complete along the way, but also this evaluation form. And please send us through any comments on this evaluation form to make sure that it fits and you can get enough, you've got the platform to get your viewpoint about the community of practice and what we're doing, so you can feed that back into us and we can tweak that form as needed. But we just wanted a starting point for today's session. Another action I've got there is to link Jackie Pottle with Gwendolyn to try and share those details so they can have a conversation about co-production in supporting in the end of life network. Then also to Gwendolyn, you mentioned about sharing the links and the cases to the benefit of co-production to help support build a case for co-production and the impact of that. So I'll summarise these and we'll share these as well. Ruth, you then mentioned about the NeuroStar, and you're going to look to see whether we're able to circulate that amongst community of practice, so thank you. And then the last one was the comments on the terms of reference and the evaluation form. So I've already written that one down and mentioned that one to yourselves. Are there any other actions that anyone's picked up that feel that we need to make sure we send out and pick up on?
Nothing from me, Nick. I think you've covered everything.
Thank you. Oh yeah, and John from so John Meredith, he's put something in the chat there. So I suppose if there's come to have colleagues on the call, but also John, what we can do is we can mention, I can speak to the colleagues and the representatives from CUMTAF who may or may not be here today. I can just put that through as well. So I'll take that as an action. So I'll put link John with CUMTAF. Morgano. Okay. Great. So last chance to say anything if anyone's got anything to say before we close the meeting. If not, we've got the next meeting, which is not finalised for the date yet. I think, Linda, you're presenting on the next one, and I've got a few things on that session, so we're just trying to finalise a date.
Sorry, I've been trying to get our site colleagues. It's really tricky with our resources at the moment, but I'll get back to you soon, probably by the end of the day today.
Okay, thank you very much, and we can circulate that date as well. And then there is one last thing. There's a nice consultation out at the moment, which is looking at the rehabilitation for chronic neurological conditions or disorders, including acquired brain injury, and the consultation closes on the 20th of May. I've had a look through this. I've had a few comments, but nothing really major, but I'd be interested to see what people's thoughts are. And just to let you know that you can register as a stakeholder and then submit some comments on the guidance. So I think you'd be in a really good place to do that. And there's definitely an awful lot in there around supporting. So, for example, there's an awful lot around supporting GPs to early identification of people deteriorating with neurological conditions, and the ability for single point of access and early access, which is a theme that we're going to discuss later in the year. And it'll be after these guidance have been submitted. So I think it'll probably be a good opportunity for us to discuss the guidance once it's published in September, to then work out, well, are we able to improve what we're doing across Wales in terms of single point of access? And is there a piece of work to be done that we can support as the exec in supporting GPs and identifying early deterioration in neurological patients in the community, and then how we can signpost them into the appropriate services to prevent them coming into a crisis point and being admitted. So that's something that we'll to discuss later on in the year, but just to flag that, and if you've got an opportunity to read through that, I think it'd be really good for us to see whether what that says and to try and influence that if we need to. Okay, well, I've got nothing else, and unless anyone else has, then we look forward to seeing you all in the next meeting, which I think is going to be sometime in June, July, but we'll get that date out to you as soon as we can, and I'll circulate the actions and all the other things that we mentioned, hopefully tomorrow now. But yeah, thank you very much, guys.
Thank you.
Thanks all.
Thanks.
Thanks.
Ellie, you okay to stop the recording and